Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Chika, DG, members of the panel, ladies and gentlemen. I want to start by echoing what DG Tedros said just now. The science was irrefutable as far as the vaccination was concerned. 90+% efficacy, safe, stable. But before I became health minister, I was science minister, as well as the coordinating minister for the national COVID-19 vaccination program. I knew what DG said was true, that the science alone would not be enough. So I went back to school. I took a massive open online course on behavioral insight for public policy decision making. Now my guys are mortified because they don't know this. They don't know that I was learning about this. And I learned about this because we could not take things for granted. We could not take the science for granted. We could not take people's behavior for granted. And you must remember, when we started the immunization program, a lot of people were already quite fatigued when it came to nudges and instructions. It had already been 1.5 years of telling them to mask up, isolate, wash their hands, physical distancing, so it was difficult. Now, alhamdulillah, we have 98% of our adult population fully vaccinated, 70% of the adult population boosted. So by no means Malaysia is an example for the world, but I wanted to share some insights briefly about what worked and what didn't work. But before that, I want to say one clear statement of intent, for us at least in Malaysia, that behavioral science is now the first line of defense for our health system. Because if you can get people to change the way they live, you will safeguard your healthcare system. And we saw behavioral insights play a big role in the pandemic, but I want to raise one important cautionary note. A pandemic or health crises or emergencies are outliers for mass behavioral change. There is a clear and present danger during a health crisis. And let me bring that into the context of what we want to do now with non-communicable disease. With NCDs, there is no clear and present danger. Yes, of course, it's an epidemic in my part of the world. The former Bank of England Governor, Mark Carney, wrote about the tragedy of the horizon when it comes to climate change. Essentially what it is that the impact of climate change is felt beyond the ordinary time horizons of decision makers. So what that means is the cost on future generations, there's no incentive for the present generation to fix. So when it comes to NCDs, we have a tragedy of the horizon of our own. Essentially, one, NCDs are not a clear and present danger as much as infectious disease. People are saying, I have no incentive to change my behavior for a problem that may or may not happen. This is the problem of intertemporal choice in behavioral science. And of course, people are tired of ministers of health telling them what to do. I think if I tell people what to do, go for health screening, I will lose the next elections, confirm. So there's a problem there. So I wanted to touch on 3 things that I think we did okay during the pandemic as a Kickstarter for our conversation. 1, for behavioral science insight to have an impact, it's important to have trust and clear communication. This is more than anything else, the question of credibility before people decide to change how they live. Context needs to be done in a transparent manner. Do not condescend or preach to people. Do not say that you're not following the science. Assume that they are also equally convinced of their point of view as you are. And for NCDs, there are so many socioeconomic determinants to health beyond exhorting people to live healthier, eat better. Sometimes it's just not possible for them. So don't assume anything. But you can use social norms, and this is something in behavioral science. So what we did is, you haven't been vaccinated, but 80% of the population has. Go for your vaccination. So that kind of social norm setting was very, very important in getting people across the line as far as vaccines are concerned. Second, make sure the information that you put out there is actionable. If you're putting out information that is not easily actionable, there's no point. It's not going to change anything. So the best form of risk communication that can lead to behavioral change is something that is easily actionable and accessible. And I'll give you an example. We had vaccine information given out through our Everyone Has a COVID app in your country, but with a booking link. T-3 reminder, T-1 reminder. In behavioral science, this is follow through, plan making, plan your journey to the vaccination center, and our attrition rates were very, very low. We translated the vaccination information to 14 different languages. We didn't assume the national language was enough, because we know this is very personal if you don't get into dialect. We brought the action close to them so that there was no barrier to action. So now we're going to do national health screening. It's not asking people to come to the hospitals or clinics. We're going to go out there into the villages to do the health screening. So it's very important to create a simple choice architecture that reduces friction so that people want to do something. And again, another thing that we did, which was very small, but led to a lot of reduction in friction, vaccination forms were pre-filled based on the information that was in the app already. Very small things. And the third thing, I know, Chika, I'm just wrapping things up, is how to design incentives and nudges. Nudges are the big buzzword, Richard Taylor's nudge. That's the big go-to holy book in terms of behavioral science. But nudges are more than just a carefully designed question or carefully designed form. It has to speak to the heart. If you don't design your nudge that speaks to the heart, that contextualizes it in the local environment, it's not going to mean anything. Example, we did vaccination at mosques because we knew that amongst the resistant community, there was a religious element to it. We did it at the mosques. We got the imams to go first. That was enough of a nudge because the imam would tell his congregation, are you vaccinated? You're not vaccinated? Please, khalas, don't come. So these are some of the lessons that we learned, and I hope that we can pursue this. I spoke with DG Tedros earlier. Malaysia is happy to work with other countries to bring this up into a resolution perhaps next year for us to draw on best practices. And one last thing, data collection is important. So I think data collection, without data collection, there will be no insights and analysis. Thank you.
Thank you.